Good afternoon and welcome everyone. And thank you for attending our grand round. It's my pleasure to introduce Dr. Rafah Fairaq, who has joined us as a consultant ophthalmologist a few months back. She graduated from Western region and did her residency there. And then she joined us in 2017 as a fellow. After her fellowship, she went back for probably a year or so. And now she's back permanently, and hopefully her presence will increase the academic output of this department. So with this, Dr. Rafah, over to you.
All right. Okay, good evening, everybody. Thank you so much, Dr. Ahad, for this introduction. It is my greatest pleasure to present the grand round today. I will be talking about drops for the regeneration of the ocular surface. The limits of this topic is way beyond a 1-hour talk. The field is very vast and the amount of information is huge. So the purpose of my talk today would be to open doors for you and widen your sight to all the possibilities of the biomedical and tissue engineering and all the innovation in the field of molecular biology and ophthalmology. So I have, one second. I have no financial disclosures to disclose about any of the products in this talk. And that being said, let's start. So I will take a few minutes to take you back to the basics, because understanding of the basic is the main base for you to understand the rationale behind all of the products that I will be mentioning. As we all know, the ocular surface is a whole environment. It's not just one or two structure. It's an environment composed of the tear film, cornea, the conjunctiva, lacrimal gland, meibomian gland, the eyelids, the nerves, the blood vessels, and everything, and also all of the inflammatory mediators on that surface as well. One particularly interesting structure of the ocular surface is the limbal stem cell niche. It's no longer called the limbal stem cell alone. It's a niche because it's multiple factors or multiple components. They're all synergistic and in certain equilibrium together. The limbal stem cells localized at the base of the crypts of the palisades of Vogt, as we all know. In that, there are also associated mesenchymal cells, pigmentary cells that protect those limbal cells from the harmful effects of the UV light. There's the nerves, there's the blood vessels, there's the extracellular matrix as well. In the normal state, the limbal stem cells are in the low metabolic state. They're not proliferating. Each limbal stem cell, when it starts to divide, it gives two products. One, it regenerates another limbal stem cell, and it gives something called the amplifying cell. Those cells, they have a slightly more rapid cell production cycle, and they are the reason, or they are the progenitor for the future epithelial cells of the cornea or any structure. But in the beginning, they start as unspecified cells, then they start to differentiate and they start to pick up the speed of their mitotic activity, and they become more corneal committed, transient amplifying cells. Then they're usually located at the basal layer of the corneal epithelium, and then they start to migrate and differentiate and so on, and they produce the normal non-keratinized stratified epithelium that we know of the cornea. Phases of the wound healing: once there is an epithelial loss or there's a problem with the corneal epithelium, it's a process, it's a very unique process of cell migration and then proliferation and further division. But first, it is preceded with a latent or lag phase. This lag phase is where the cells change their metabolic activity. Remember, I told you the stem cell is in zero metabolic state at the beginning, and then it starts to pick up their metabolic speed. And that's what happened. After 5 hours, about 5 hours from the epithelial injury, they start to migrate. The cells start to migrate, of course. And of course, this is all mediated by growth factors that I will be mentioning in the second slide. Anyway, so they migrate to fill that gap. Then they start to form adhesions like the hemidesmosomes and the desmosome with the underlying structure. They migrate, then they proliferate first, and then they stabilize themselves with the formation of the adhesions. For this flawless corneal wound healing to occur, it requires high level of energy, intact limbal stem cells, healthy environment that includes the tears, the immune cells, the corneal innervation, and the signaling between cells. Here is a zoom in for one of the beginning, the first stage of the corneal wound healing, where once there is a break, the interleukin-1 cytokines start to activate the keratocytes. Platelet-derived growth factors start also to modulate this proliferation and migration of the cells. Also, transforming growth factor beta also activates the myofibroblasts, which are responsible for the extracellular matrix production and the fibrosis and all of these components of the healing. Other factors like epithelial growth factor, insulin growth factor, they promote the epithelial cell proliferation and differentiation. I mentioned that already about the limbal stem cell, how they migrate and start producing more differentiated corneal epithelial cells. When a disturbance of the equilibrium happen, like for example, dry eyes or a chemical burn or any of these problems, what happens? There's a constant state of inflammation. This inflammation attracts the inflammatory cell. This presence of the inflammatory mediator, it limits the regenerative potential of the ocular surface and causes the limbal stem cell to lose their capacity to rehabilitate the surface and produce new cells. And this defect causes further inflammation, and so on. It goes in a vicious cycle. Therapeutic approaches, for you to understand the concepts of treating an ocular surface, these are the broad categories that I would like you to understand. First, the cell-based approach. The cell-based approach is where you supply the deficient cells. Like, for example, you have limbal stem cell deficiency, you supply the limbal stem cell. You have the mesenchymal cells deficiency, you can also transplant these. The extracellular matrix approach, like as I mentioned, it is part of the limbal stem cell niche and the ocular surface having a healthy extracellular matrix. So that's when, for example, you provide the amniotic membrane, which acts as a scaffold for the cells to grow hydrogel extracellular matrix, and other recombinant matrices also work in this area. Therapeutic factors based approach. This is our talk today. We are talking today about all the factors and the mediators and all of these that help or are part of the whole ocular surface health and well-being. Okay. First of all, the first of these is the amniotic membrane derivatives. All right, the amniotic membrane derivatives, as we all know, the amniotic membrane has a lot of anti-inflammatory, healing, promotion properties, antibacterial, and all of these. So what's new here is the amniotic membrane eye extract drops. We don't use the amniotic membrane itself, we use it in the form of drop. The whole purpose of using these drops is to look for simpler ways to deal with these very unsimple problems. In the preparation, briefly, it is you harvest the amniotic membrane, they clean it, and they, of course, after serological testing to make sure there's no like any viruses, hepatitis or HIV or all of these. They clean it with antibiotics and all of that, and then they freeze it. After freezing, they make it into powder form, and then that powder form is mixed into something, and with centrifugation, all of these factors will come out. This is an application of how the amniotic membrane drops, how they affect the ocular surface dynamics. Like we mentioned, the amniotic membrane has high numbers of hepatocyte growth factor, epithelial growth factor, fibroblast growth factors. All of these growth factors, they promote the limbal stem cell differentiation and proliferation, and hence they promote the corneal wound healing and regeneration. They also have factors that contribute to the development of the extracellular matrix. These are the fibronectins and the other collagens that are also important for the migration of these cells on this extracellular matrix. They have anti-inflammatory effects. This occurs through the increase of the interleukin-10 and the decrease of the tumor necrosis factor and the other pro-inflammatory interleukins like interleukin-6 and 8 and 12. And this inhibits the macrophages and the other inflammatory cells. They have a very excellent effect for preventing the scar formation and the fibroblast activity through the downregulation of the transforming growth factors 1 and 2. Another complex, it's the heavy chain complex. They say that it has some effect on the angiogenesis. Of course, the concentration of these factors varies according to the preparation methods. There's just so many preparation methods. The one I mentioned is just one of many, and each preparation method yields a different concentration of growth factors and cytokines and all of these mediators. So it is important to understand the limits of your preparation methods before applying it clinically. In this review of literature, we found so many studies talking about the benefits of the amniotic membrane eye extract drops. They reduced the inflammation due to the properties that I mentioned earlier, their interleukin mediation properties. They reduced the pain and significantly and the symptoms of the patients, especially in cases of chemical burn, as found by Shiha and al. They promoted the corneal epithelial healing, which is the most important thing. And they also not just promoted it, they did that faster. So they minimized the time where the epithelial defect was present, which is also which also has a beneficial effect on the final outcome of the patient in the sense of prevention of infection, overlying infections, prevention of scarring, formation, and melting. These are just some of the applications. They were used in mild to moderate acute chemical burn, infections, and peripheral corneal inflammation after limbal transplantation and after corneal surgeries to promote the epithelialization in bullous keratopathies and partial limbal stem cells. It's important here to point out that these drops, although they retain the mediators and the growth factors and all of these properties of the amniotic membrane, however, they are devoid of the structural integrity of the membrane. So we lose the epithelial scaffold property of that membrane. It's beneficial sometimes to use them in combination with amniotic membrane transplantation in the cases that needs this form of intervention. And they, in that sense, they will help to provide a continuous supply of these factor with the continuous application of the drops. This is now we go to important questions about every drop. Which is better, the drops or the amniotic membrane? We found that study, it's a comparative study done in 2011, where they got the rabbit eyes. They performed an 8 mm epithelial defect, and then they divided them into a group that received the amniotic membrane transplant and the other that received the drops. They found that the diameter of the heel of the size, the diameter of the epithelial defect decreased in both the amniotic membrane and drops and the transplant, and it was to a comparable extent. And also the rate at which this happened also was comparable. Yeah, this is another one. So I'm going backwards, sorry. Okay. All right. This is all talking about the closure rate and all, and I'm going to skip that in the interest of time. I included the studies for you in case you want to go back for reference for any further details about the protocols of the study. So what are the advantages of these? First of all, they don't need an operative procedure. As I mentioned, they prolong the efficacy of AMT through the intermittent delivery of the mediators, and it also can contribute to the healing. The disadvantages, like I mentioned, the non-standardized manufacturing processes. There's different processes that will yield different concentration. There's also a challenge in preserving these components without losing their effect. They have a short life. The drop is about a week, valid for about a week. And also the microbiological safety in the form of transfusion of any, transferring of any viral illnesses, since it's a human product. Blood derivatives is the other topic that we will talk, and this is the one that we most commonly use. In 1975, people started using the idea of drops through a mobile perfusion pump over the alkali burn. In 1984, Fox and his group described the the autologous serum drop, in Sjogren syndrome, and since after that, they become more popular. The clinical application, again, they are used in dry eye, persistent epithelial defect, recurrent erosion, neurotrophic, keratitis, limbal stem cell, ocular graft versus host disease, and post-keratoplasty and post-vitrectomy or any retinal surgery with induced epithelial defects. Okay, what's the rationale behind using them? They have strong similarity to the human tears in regards of the pH and the osmolarity. They are rich in nutrients, growth factors, vitamins, and cytokines. Like we mentioned, the epithelial-derived growth factors, the platelet-derived transforming growth factor, all of these factors are important for proliferation and differentiations of the cells. Vitamin A is an important molecule present in the serum. And the role of it is that it prevents the epithelial metaplagium, as well as inhibits the vascular endothelial growth factor, which controls the angiogenesis. Neurotrophic factors like the insulin-derived growth factor and the substance P, which have important role also in the migration and adhesion of the epithelial cells. Fibronectin is also an important component of the matrix that promotes cell migration. Alpha-2 microglobulin, this is an important factor because it has an anti-collagenase activity, so it prevents melting in cases of those cases where they are having their stroma exposed. They're naturally preservative-free because they have the IgGs and the IgAs and all of these immunoglobulins and the lysozymes. So this is a very good advantage because we all know the drawbacks or the side effects of the preservatives in any drops, especially in those sensitive ocular surfaces. So how we prepare that? Briefly, we take the whole blood, we leave it to clot, and this is an important differentiation here. We leave it to clot for 2 hours in room temperature. Then we centrifuge the transparent fluid that's remain. This is the separated supernatant, and then we dilute it according to the concentration that we want. It is good to be stored at degrees of minus 20 degrees Celsius in the freezer for 3 months. Once it is thawed in like the fridge, which is 4 degrees Celsius, it is good for about a week. And it should be away from light to protect the vitamin A. The drawback, again, no standardized preparation or storage protocol. There's risk of contamination. For example, if there is any viral infections, whether for the people performing the procedure of the autologous serum, or for the people if any mix happens between patients. For example, they give some drops to the other patients. This is why only most of the studies, they always specify in their protocol that a single blood sample was managed at each time, so to prevent mixing. Another problem is the difficulty with accessing. Not all hospitals or not all ophthalmology centers have access to laboratories who are capable of performing such a procedure, or who have serology testing or have phlebotomy services. So this is a great challenge for small ophthalmology centers. Different concentrations, we know the 20%, the 50%, the 100%. The rationale behind diluting this serum is that in earlier days, they found that the concentration of transforming growth factor beta is about 5 times that of the tear. The worry or the point here that the transforming growth factor beta has a pro-inflammatory effect that are dose dependent. So if you have it in a higher dose than required, it becomes it does the opposite actually, which promotes the inflammation. However, in that study, they used a lower speed for centrifugation, and this is what led to the false overestimation of the transforming growth factor beta. With more recent studies where the faster centrifugation is used, it's a lower number, or it's a lower concentration. This led that people are trying now to, or they are more encouraged to use the higher concentration of the serum BSS. In that way, they can get more of growth factors without worrying about the effect. This is one of the very nice studies comparing the effects of the autologous serum with different, not just concentration, but also different dilutants. For like when I mentioned that we get the supernatant and then we dilute it to the to the certain concentration that we like, what do we use? We use sometimes serum BSS, but others proposed that if we use the sodium hyaluronate, which has higher viscosity, this will lead to the lasting of the drop for a longer time and on the ocular surface. In this study, it was a prospective study, and they got patients with Sjogren syndrome and persistent epithelial defect and non-Sjogren syndrome. They had 100% concentration of autologous serum, and they noticed, and the other groups, they had 50% concentration of autologous serum. And this 50% group was subdivided also to another 2 groups, which are the ones with the serum BSS dilutants and the other one with the um, with the sodium hyaluronate. They found that 100% autologous serum drops was significantly better in the speed of the epithelial closure and the improvement of symptoms and the corneal epitheliopathy in patients with Sjogren syndrome and persistent epithelial defect. However, when they did the comparison for the patients with the 50%, in non-Sjogren syndrome, it was comparable to the 100%. So in non-Sjogren syndrome, 50% serum drop with normal saline showed similar effect to 100% serum in the terms of symptoms and corneal staining. And they did not find any synergistic effect for the hyaluronic acid when combined with the serum eye drops, although there are other studies reporting otherwise. What are the benefits of the 100% autologous serum drops? They have a higher concentration of growth factor. There is lower risk of contamination of the drops because you don't manipulate it. You just withdraw it, centrifuge it, and that's it. You take the supernatant. You don't have to manipulate, adding serum BSS and doing multiple dilutions. However, this altered osmolarity and pH preparation sometimes may cause discomfort when applying it to the eye. Another problem is the frequency of blood withdrawals. In order to get this much concentration, you need to do a lot of blood withdrawals, which might not be feasible for some of the patients. Another thing is the cost, which it costs about 240 US dollars to have a 3-month supply of that drug. In this regard, maybe having the medium one, the 50% autologous serum drops, may be more convenient and still have the effect of a higher concentration of growth factor than the regular 20% serum. In some instances, some patients are not able to give their own serum, like if the patient have no access to their peripheral veins, or they have other systemic comorbidities, bleeding disorders, they're taking anticoagulant, they have altered serum concentration, like in patients with chronic renal failure. Possibly in Sjogren syndrome and graft versus host, they say that they have a different component of their serum. In that case, they use allogenic serum drops, where they take the drop from the blood from a different person. However, they need to have blood grouping and hematoimmunological AB antigen matching for that. Before I go to the next part, I need you to understand the difference between plasma and serum. What I was talking about just now was the serum. Okay, in the preparation, if you remember, I mentioned that you have to leave it to clot naturally for 2 hours in room temperature. So we don't need to put anticoagulants. But in the plasma, the difference is the plasma it's the clear fluid in the blood. However, it still has the fibrinogen and the clotting factors. Okay, so this is why we have to put anticoagulants in the withdrawal tube. Okay, what are the other plasma products? These are the plasma rich in growth factor. This is one, and then there's another one I'll mention now. The plasma rich in growth factor is an autologous platelet rich plasma. It is rich in all of these growth factors that we have been talking about. It is prepared through centrifugation, and of course, this tube has an anticoagulant in it. It is centrifuged at 805 for 8 minutes, and it's collected in a tube and incubated for 1 hour in a degree of 37 degrees, then it is heat treated. The purpose of this heat treatment is to to make it more immune favorable. Okay, after that, the filtration, then again, it is stored in a -20 degrees for maximum of 3 months. The whole centrifugation technique, it has a lot of details, which once it is centrifuged, they put a substance that causes the platelet to degranulate and release their growth factor. This way they have more concentration. Anyways, there's most of the studies are using the machine and a specific machine, and this is called the Endurit machine. So in the clinical evidence, one study was about treatment of neurotrophic keratitis with this plasma-rich and growth factor eye drops. It was a retrospective study comparing patients with evaluating the outcome of patients with neurotrophic keratitis stage 2 and 3 from different pathologies. And they had these drops applied 4 times a day for 6 weeks. And let's see the results. The results, of course, here you see the different pathologies. There's herpetic neurotrophic, there's secondary to corneal surgery, secondary to dystrophies, and other factors. The results show that there was complete resolution achieved in 97% of the eyes that were treated with the platelet-rich growth factors. And the mean time for this closure was about 11.4 weeks with standard deviation, of course. They measured different variables outcome, not just the closure. They measured also the best corrected visual acuity, the ocular surface index, and all of these. And they all had favorable response with the platelet-rich growth factor. The interesting theory here, and this may influence our practice, is that they noticed, like I mentioned, they talked about not just the closure of the wound, but also about the outcome of the visual acuity and also the time required for this defect closure. But they found that patients who were previously treated with autologous serum had poor response in regard to the visual acuity recovery. They hypothesized this, that it could be due to the fact that the patient were already, or their cornea were already exposed to the cytokines and the transforming growth factor betas and all of these pro-inflammatory and scarring factors. But in this sense, they ended up with more scarring and hence the lower visual acuity improvement. The resolution time was also significantly shorter if the patient did not receive autologous serum before. It was 8 weeks compared to 29 weeks. This may tell us that maybe it's better to immediately start the patient on such therapies in the interest of preserving their time and giving them a better outcome. Another study, this is just also to tell you what other studies in which pathologies it was used: dry eyes, ocular surface syndrome, persistent peel defect, chemical burns, and all of that. All showed favorable outcome for the plasma-rich growth factors. An important question is, what is more beneficial, the platelet-rich the plasma-rich growth factor or the autologous serum? Anita did an experimental study, and they divided the study groups into a group that will receive the plasma-rich growth factor and the autologous serum. They did they did evaluation, proper evaluation of the content of all of the factors, the growth factors and all of the mediators and all of that prior. So they had the exact concentration of growth factors and mediators in both the autologous serum and the plasma-rich growth factor. And then they wanted to see what is the difference in the proliferation of cells in both the corneal and the conjunctival cells. So here you can see there's elevated proliferation with the plasma-rich growth factor. Here's the control, and here's the plasma-rich growth factor, and here's the autologous serum. It's clearly, there's more proliferation of cells in that group. They also wanted to see the effect of scarring. So they measured the markers of the myofibroblasts, which is the smooth muscle actin alpha, and they found, they did also the immunofluorescence photographs for that, and you can see here that with the patients, I told you that the transforming growth factor, it stimulates the myofibroblasts. This is why they used it in conjunction with each of the therapeutic option. So here this group is the upper group is the conjunctiva, and the lower group is the corneal tissue. In the transforming growth factor beta group with the plasma-rich growth factor, we found the least amount of myofibroblast activation and growth, which translates in less scarring. To answer our question, the the plasma-rich growth factors has a better outcome in form of promoting the epithelialization or the cellular proliferation, and also decreasing the scarring. I keep saying platelets because I'm excited about the other topic, the next topic. So what is the platelet role in all of this? We found that the platelets has a 30 times more higher concentration in their alpha granules than any other product. They have the platelet-derived growth factor, epidermal growth factor, VEGF, and all of these factors. We already talked about their role in the healing process, but the main thing here that they have a higher concentration in the platelet granules. This was their rationale to use the platelets as a product. Here again, they need to withdraw the blood in a tube with sodium citrate that prevents coagulation. They did centrifugation first, gently. This separated the blood into 3 layers. This upper part, it's composed of plasma with some platelets. The white part, or the buffy coat, this one contains white blood cells and the red cells. They take only the upper part, this supernatant, and they centrifuge it for a second time with a higher speed, and they come up with a platelet-rich plasma. And again, this is stored in -20 degrees Celsius. Clinical application is applied in dry eye, Sjogren, persistent field defect, neurotrophic keratopathy, chemical injuries, and recurrent erosion, as well as post-corneal refractive surgery. It was helpful in the relief of symptomatic dryness. We go to another group, which are the growth factors, particularly the nerve growth factor. I'll go back to what is the importance of the corneal nerve in this whole dynamic of the limbal stem cell niche. So the nerves, they mediate the protective tearing and blinking reflexes, which are important for the whole environment to be healthy. And they release neuropeptides like substance P and calcitonin-related peptide, which are very important mediators for cell migration and proliferation. On the other hand, the epithelial cells they release neurotrophic factors that also enhance the nerves and as well promotes the proliferation of epithelial cells. So it's again, it's a cycle. Neurotrophic keratopathy is beyond our thought. However, I wanted to shine the light on the grading because we will talk about the grading in the upcoming study. Grade 2 is where there is persistent epithelial defect, loose epithelium, loss of stromal tissue, and beginning of melting. These are the therapeutic modalities of conventional treatment. We all know them. The new thing here is the Saint-Germain growth factor, nerve growth factor, known by the product name observate. It's an ophthalmic solution containing 20 microgram per ml of recombinant form of human nerve growth factor. It's produced in E. coli as a propeptide. Once you apply that into the eye, it becomes cleaved into the mature nerve growth factor, which binds to the cell and regulate their growth and survival and differentiation of the nerve cells. How is it prepared? It's prepared in a sterile, preservative-free ophthalmic solution containing this 0.02 milligram per ml of active ingredients. The box comes with 7 multi-dose vials. This is one vial, okay? And each vial is valid only for 1 day. You can use it for 1 day. And every time you use a different pipette to apply it. Every time you put your drop, you use. Okay, so, and it's stored between 2 to 8 degrees up to 14 days until the time of use. This is after you start using it. How often is it used? It's 6 drops per day, Q2 hours for up to 8 weeks. This is important. Why? Because it will reflect on the cost of this product. Of course, you cannot wear it with, you cannot apply it with contact lens because it prevents the diffusion and of the drop. It is very important to keep an eye of tumor progression in patients with cancer because this is a growth factor. So we still don't know their effect in stimulating the further growth of neoplastic cells. Also, in eye infection, we should not use it in an eye with an active infection. We should treat the infection first, then use that. Also, it is not feasible to use in patients who require surgical intervention. Mechanism of action, it stimulates the growth and survival of epithelial cell, maintain limbal stem cell potential, and it promotes the tearing by binding to lacrimal glands and support corneal reinnervation. So it's a super drug. A very nice study, it's a randomized controlled trial, double-blinded, multi-centered with vehicle control, where they use different concentration of the Saint-Germain and in stage 2 and 3 neurotrophic keratopathy. And this here, I would like to say that this is one of the few approved, FDA-approved drops for neurotrophic keratopathy. In the outcome, they measured the outcome at 4 and at 8 weeks. In each time interval, the group that had the Saint-Germain drops were way better in their performance, in the percentage of people with corneal healing. They had different classification of their corneal healing, whether they allowed a 0.05 pinpoint CED left, or they wanted a complete resolution of the CED. Either ways, the Saint-Germain was way ahead. The drawback is what? The multi-step administration procedure. Like I mentioned, you have to change this pipette and all of that. The storage condition, it needs a freezer and it needs to be out for 30 minutes before you can use it. And the treatment cost, which the cost for 8-week course is about 14,000 pounds. Insulin-derived drops is another innovative group of drops. They are prepared by injecting regular insulin, which is readily available, into polypropylene glycol and glycerol in a concentration of 1 unit per ml. The drops are refrigerated for up to 1 month. The mechanism of action is, like I told you, the insulin growth factor. It has a positive effect on epithelial cell migration and as well restoration of the corneal nerve. This is why I started my talk with the whole back to basics. I know we don't always enjoy going back to these complicated factors, but they are really the base of all of these innovations. Using topical insulin, we have this case series where they used the insulin for 6 patients, and all of them, they showed complete corneal reepithelialization between 7 to 25 days from treatment. They had different reasons or different underlying pathologies. As for the side effects, only 1 patient developed crystalline keratopathy, but they assumed that this could be due to the chronic steroid use rather than the medication itself. Coenzyme 10 is another important factor. However, it acts in a different way. It's not one of the growth factors that I mentioned. It is a electron transport. It's a complex that attaches to the electron transport complex 1 and 2 and 3 of the mitochondrial respiratory chain. I will show you here the function to understand it. So this is a mitochondrial electron transport chain, and these are the complexes 1 and 2 and 3. And here you see the coenzyme Q10. It is a lipid-soluble molecule and attached, and it has a very crucial role in modulating the permeability of the electron transport chain, which is important in production of ATP. What's the rationale behind it? Like I mentioned, it's important in the electron transport chain, and this results in ATP production. So it preserves and enhances the mitochondrial energy. It's anti-apoptotic because it modulates the permeability for molecules. It's antioxidant. It's a scavenger for all those free radicals. It's anti-inflammatory, and as well, it's a help in restoration of the subbasal nerve plexus. The formula available is of the coenzyme Q10 100 milligram with vitamin E and hypermalose. It is presumed that the vitamin E, it increases the antioxidant effect of the drug, and the hypermalose, it adds more viscosity and helps it stay longer on the ocular surface. This is a review and a case series of using this coenzyme drops for treatment of refractory corneal ulcer. Again, there was different underlying pathologies like neurotrophic ulcer post-infection, post-acanthamoeba, Stevens-Johnson, dry eyes, all of that. It was used variably between twice a day to 4 times a day. And most of the cases responded within 4 to 8 weeks. Only 2 cases responded faster in 2 weeks. Another study that was really nice, where they used the coenzyme to just without having after regular cataract surgery, without having any ocular surface problem, and they just evaluated the effect of healing after the surgery. But they found that the Q10 group were associated with faster nerve regeneration, and they had better stability of the ocular surface. And also they did confocal microscopy, and they found they had more regeneration of their and faster regeneration of their basal nerve plexuses. No side effects were noted. Okay. These are other newer agents. The regenerating agent, RGTA, it's a matrix, a new matrix agent. It mimics the lost heparin sulfate. We know that heparin sulfate is one of the components of the corneal stroma. It mimics the action and regenerates a new extracellular matrix. Also, there is the all-transfertonic vitamin A. Like I mentioned, vitamin A has a role in stimulating the proliferation of the corneal epithelial cells and maintaining its integrity. Last but not least, the answer to our question at Cakeish, where do we stand? At Cakeish, luckily, we have local preparation. We have the facility to prepare our own autologous serum drop with different concentration. We have the 20%, the 50%, and the 100%. We are also lucky enough to have a well-equipped eye bank, and we can prepare our own amniotic membrane and preserve them. We have available the Endoret, the plasma-rich growth factor that I told you about. We have the machine for that. We are working on the process of getting a pre-market approval from the Saudi FDA for the observate or the Saint Germain, since it was approved by the FDA and the European. We are working or we have multiple research projects led by Dr. Ahad about the coenzyme 10 therapy. We have a case series and also the amniotic membrane eye drop for management of corneal persistent epithelial defect. And I will end my talk by letting him tell us more about the challenges he faced during working on these two promising projects. That's it. Thank you all for listening. And anybody has any question? I hope I didn't overwhelm you.
Thanks a lot, Dr. Rafah. It was, yes, very rich. You know, when you eat a very heavy kabsa, so full of protein, so full of basic sciences. I mean, I learned a lot. I learned a lot here. Any questions from the audience? I see quite a lot of anterior segment faculty are there. If they have any questions, Dr. Rafah is here to answer. Okay.
Yes, please. Dr. Ahad?
Yes, sir.
This is Dr. Faisal Jassar.
Dr. Rafah is for you.
Thank you so much. I hope you are doing well. Thank you, Dr. Rafah, for the great presentation.
You're welcome.
What happened? Who muted you?
I can't hear you, Faisal.
Do you hear me now?
Yeah, now I.
Yeah. Regarding the amniotic membrane eye drop, can you repeat how do you prepare it?
There's many ways for the production. One of it is through freezing it. We get the tissue just in the regular process of harvesting the amniotic membrane, like we do. We have the serology test, and we wash it with the streptomycin and all of the antibiotic and like that, and then we freeze it. And then after freezing it, we mix it. We break it into like powder. And then that powder we use it and mix it to become liquid again, and then we centrifuge it and get the factors out of it. Correct me if I'm wrong, Dr. Ahad.
No, you're totally right. And Faisal, we sort of standardized, well, not standardized our technique, but we have got a technique which we are planning to use. Our study is at the moment with SFDA for final approval. Shortly it will be approved. They keep asking us different questions. And there are different ways of producing. The way which we choose was one which we have got the tools and expertise to do. And the other thing was to make sure that we get mostly the sort of an epithelial drive or for epithelial defect rather than for anti-angiogenesis or anti-inflammatory. So the different ways of making it depends upon what you want most out of it, whether you want sort of something to heal the corneal epithelium, or you want it for anti-angiogenesis or anti-inflammatory. So that will sort of differentiate. And hopefully we'll have a better answer, I think, next time this year.
Hopefully.
Yes, with Q enzyme Q10. I mean, that was funny. It was very small, sort of an Italian company which was making it. And obviously a paper went through my, I think it came for a review or something. And I said, okay, I will decide it. So I had a couple of patients. One patient was with diabetic sort of a keratopathy, a young lady with end-stage disease. And the other one was having a pterygium surgery, and she had mitomycin used a couple of times. And I said, can you, I mean, I could not get a hold of it in UK. So I said, can you guys buy it over the internet? So one of them got it from Amazon, and the other one contacted them directly. And in 2 weeks, they both healed. And then after the publication and things like that, a British pharmaceutical company, they bought that company, or not that company, the rights of this drug. And then they started a trial in 2018. Now they have marketed it with the name which you showed. This is the one which is the British drops. And funny enough, I mean, it hasn't sort of flown that high up as one was expecting. So maybe it depends on the type of patients, and the thing which it does is basically, it's like increasing the energy stores. So the epithelium, there is epithelial mitosis, migration, and proliferation. So if you have got a good sort of reservoir of these cells, it will work. But if your cells are gone, then probably it is not that effective. So you need to have a
I have one question here from Dr. About if there's any comparative trials between all of these products. No, not really. The comparative trials are the ones that that I mentioned, but none of them are well-controlled, randomized trials and sort of comparison. The one I showed you, the one where they compared the plasma-rich factor and the autologous serum, that was on an experimental study as well. Yeah, we don't have that, unfortunately. And there's very high variation with the costs, depend on the method of preparation and your facility as well.
Assalamu alaikum.
Walaikum salam.
Thank you, Dr. Rafah, for this wonderful presentation. Really, you summarized most of what's available in the therapeutic, shelf of medications. As you mentioned, that there are a lot of disadvantages. So these medications are not commercially available, right? And then they require special preparation, and some of them also, even if they are available, like the amide, they are not approved, right? So, did you come across any flow chart that would summarize which medication you would like to start in each group? For instance, if you have like a persistent epithelial defect, what would you go to the when would you go for the autologous serum? Just as a start. If you have a chemical burn, would you start first with this before that one? Is there any like a flow chart that you came across when you review this?
Unfortunately, among all the review articles that I read, they all, in the end, it was always the comment that there is no consensus on the guidelines for when to use which and what are the protocols and what are the concentration. But this is actually one of the major drawbacks for these medication in all of the groups that I mentioned, that there is no specified protocol for any of these. It's I think it's left to the discretion of the treating physician.
Got you. So guidelines probably is one of the things that probably needs to be done in the future. Yeah.
So, Dr. Rafah, if I can just add to that, and this is based on just like my study rather than my study, like my reading rather than anything else, is that the plasma rich, if you're talking about the serums and the autologous drops, the plasma rich has got more nerve growth factor and insulin growth factor. So it is probably more sort of indicated for neurotrophicity sort of a case. Okay. If it's a platelet rich, it has got a lot of epidermal growth factor. So it is very good for a persistent epithelial defect.
Okay. Yeah, so that's applying the basics. That's applying the basics. Nice.
Got you. And then if it doesn't work, then you go to the next step, which is the synergy, something like that. Is that what you're proposing, right? You go to the more concentrated one, right?
And the more expensive ones.
Yeah, and a more expensive. Okay, so it will be still subjective, as to the availability and, as you mentioned, to the cost, probably. Thank you.
You're welcome.
Good afternoon.
Hello.
Yes.
Hi, Dr. Azario.
Hi. I have one comment regarding the topical insulin. You show only one study and only one case report, but there is 2 clinical trials that demonstrate that it's so effective, the topical insulin in neurotrophic keratopathy. And the price is so cheap because it's more or less around
available
$2 the treatment a month. Before the Regeneration, maybe we could try to start the preparation of the topical insulin in our pharmacy. And later on, we can move for more expensive treatments. And it's so easy to prepare. Even I discussed more or less 3 months ago with the pharmacists in the hospital, and they're willing to prepare. But we need to create the protocol, and after that, they start with them. But in my opinion, we have to start first with the topical insulin before move to the Regeneration. The price of the Regeneration is so
expensive.
Yeah, it's actually a very valid point. Yeah, it's
insulin drops. Again, I mean, there are, like I was talking about, like coenzyme Q10, even hyaluronic acid. When you talk about, I mean, on papers, when you do it on the animal studies, not on animal, like experimental studies, it promotes epithelial healing and migration excellently. This HA, hyaluronic acid, or sodium hyaluronate. The moment you put it on the as a drops in your eyes, it doesn't work as great. So there is something else in the tears maybe, which prevents the way it works in the lab. And same is with the insulin drops. I mean, it doesn't do that great that it looks great on in the experimental sort of thing. So, but Harnan is quite right, I think, and I discussed with them as well. I think me and Harnan can do it together, or all the entire segment Dr. Samar and whoever is interested, and we can probably derive a sort of a protocol here about using these drops, including you, Dr. Rafah, who seems to be quite interested in epithelial regeneration.
Yeah, it was actually a very interesting talk, and like I mentioned in the beginning, it was eye-opening how much advancement there is in the field. It's marvelous.
Okay, all right. If there are no questions, I think we can finish it here because it's 3 o'clock, and
yeah,
that makes sense.
Yeah.
Thanks a lot, Dr. Rafah, and thank you everyone for coming and listening to this wonderful talk. Thanks a lot.
You're most welcome, and I'm very happy to have this opportunity. Yeah.
Thank you.
Thank you.